Hello everyone, my name is Heath Wilt. I'm a practicing cardiologist. I have a lot of interest in what we're going to talk about here today, and I'm really pleased that this is my 4th year participating in the LIV event. So again, great honor and privilege to be involved, and anytime we have an opportunity to talk about heart health and education and talk about how to keep us in optimal condition, I'm all for it. So even though this is a little bit of a different venue, I think we'll still get a lot accomplished. So what I thought I'd do today is I thought I'd talk to you guys about a lot of the general basics that I see in my practice. As a general practicing cardiologist, a lot of times I get a lot of patients that are coming to me for the first time, and they have a lot of questions, and sometimes they don't even know what to ask. So I formulated a talk that I called Cardiology 101. And the idea here is that we're going to talk a little bit about some of the basics that maybe you should expect if you or a loved one are getting involved with cardiovascular care, or maybe what you need to do to avoid having to go see a cardiologist. So here's the aim that I really want to outline for the talk today. I really want to give everyone here a good understanding about cardiovascular ailments, and more specifically, kind of the things that would lead us into some of the more common problems that we see in the heart world. And then we'll kind of move into some of the typical medicines and things that we may be able to do through diet and lifestyle to either treat or mitigate some of those complications. So one of the things I always talk to my patients about when they're coming to see me for the first time is talking about the heart, really getting a good understanding about how to understand it in a simpler outlook. So I always tell people, think of the heart like a house. Within that house, you need to know the structure. How well are the walls holding up? Or is there a leaky roof or a drafty door or something wrong with maybe perhaps the walls not being sturdy? So we're going to talk a little bit about how that heart and the structure stands up. And like any good house, inside there you're going to have some electricity. So the electricity is very important to keep that heart moving and the electrical current moving to create a nice normal heart rhythm. And then, of course, you wouldn't have a good house without a good plumbing supply. So within this, we'll talk a little bit about where the plumbing comes in, or more specifically, the blood flow to the heart, or if there's a lack of blood flow and what that means. So first, let's talk about that house itself, the cardiac functioning, or how it stands up. When we talk about the function of heart, we really need to know where is the strength of the heart. Are there problems with the way the heart is moving the blood? And so we talk typically in terms of heart failure or leaky or narrowed valves, or sometimes there's a problem with the walls and there's a leak between the two chambers or sides of the heart. So let's get into that a little bit more. When we start talking about how to identify how the heart is working or the structure of the heart, the workhorse test that we use is something called the echocardiogram. So here on your screen in the black and white, you'll actually see a person's heart moving. And inside that heart, you'll see 4 different chambers, which again, we'll talk about in a second. But this echocardiogram, this is a common term you'll hear about when we're going to look at and understanding how the heart is working. The value here is it really helps to show the heart in motion better than really any tool that we use to date. And with that, we sometimes will calculate how well the heart is pumping. We call that the EF, or ejection fraction. And then I told you about those doors. This is one of the best tests to see them actually in motion, how those doors are moving back and forth, and are they allowing the blood to move the way it needs to. So when we start talking a little bit about the different problems, one of the other tests that we can sometimes use is something called a CT scan. CT scan really has a good role in cardiac imaging. One of the best tools that we can do to identify whether a patient is maybe not having active problems but being at risk for problems is something with a calcium scoring test. And this could be a really good test you could talk about with your provider that might help you identify someone that might be healthy, or that you have an idea about, or you want to know, are you going to be at risk for long-term problems? So a CAT scan, or a simple CT scan of the heart in the right context, like you see here on the screen, will start to show some of the early changes. So this is not a stress test. But with this particular image, a cardiac CT, or calcium scoring specific, you'll be able to see the heart in silhouette in plain black and white. And sometimes you start to see the little white spots that indicate the early changes that might suggest the potential for a heart blockage. And we'll talk about blockages in a second. But with the screen here, the first top corner, the first one, you'll see a heart that looks beautiful. You can start to see the blood vessels outline themselves. They look clean, free of any disease from afar. And then as you move into the second, third, and bottom 4th image, you'll start to see some heavier white plaquing. And that's the calcification. Again, doesn't imply a blockage, it just means that's the potential. Kind of like the basement that you would build the house on. Here you can actually see a little bit of a different form of the CAT scan, and this is where we've actually injected a dye. So this particular CT goes a step beyond, and now we can actually see the heart in motion. We can reconstruct in a 3D measurement and really get a good idea of what that heart looks like, where the blood vessels are. On the left-sided pictures, not only do you see that white little speck, that early calcification, but now you're actually starting to see the darker gray areas, which are the early blockages forming. In the middle screen, we can actually move through and actually start to see the inside chambers of the heart, maybe even a little bit more detailed than what we saw with the prior image, the echo. And on the last one over here on the right side of the screen, you're going to actually see that 3D model of the heart, which gives a beautiful outline of the heart, can be very helpful in certain cases. Some other tests that we might use is something called an MRI. MRIs are relatively new in the cardiac world. But this is a perfect test if we're really trying to get an idea of what the makeup of the walls are or the structure of the heart. The one that has the color shows that this heart muscle is starting to be infiltrated with a certain disease process called sarcoidosis. Again, something that's quite unlikely that you might hear, but again shows the role of this particular modality showing the makeup of the muscle. In the top right screen, you're actually seeing a heart that's in motion, kind of like we did with the echo, but now you're starting to see that a really generously thickened heart that shows something called hypertrophy. This is a heart that's getting too big and may be at risk for not working very well. The bottom left, you start to see the heart in a different outline, but there's mixed or a mosaic color where there's blacks and whites, and that indicates an old scar pattern of the heart. And down in the last corner, you'll see that the heart is actually moving blood, but within those doors or those valves, there's actually problems with the way the blood is moving through there. So the MRI has a really great role for identifying certain characteristics of the heart we might not see by other tests. So again, let's go back to the way that the heart works. One of the more common ailments that I see in my practice is heart failure. A lot of people have heard about heart failure, but what heart failure means is that there's a problem or a lack in pumping strength typically. Now, there are other types of heart failure, but most commonly, you'll hear about that EF, or the ejection fraction, being reduced. So again, on the screen here, you're seeing that normal pumping strength. And what we would see in heart failure is the heart that's going to start to weaken. I'll show you a picture in a minute. The question is, what's causing heart failure? Well, there are two main types of heart failure. There's what we call ischemic and non-ischemic. And as a general breakdown, ischemic means there's a problem with the blood flow to the heart. So think about having a great sports car, but the engine doesn't want to run. Is it a problem with the engine itself, or is there a problem because the gas isn't getting to it? And in this case, it's the gas isn't getting to it. With ischemic heart failure, it means there's a problem with the blood flow to the heart. And with this illustration here, the more common version you would see a problem with blood flow is because there's plaque buildup. There's something impeding the blood flow to the heart muscle itself. And with ischemic heart disease, this is where we might have to start looking for things like a plumbing problem or blockages that need to be fixed. With non-ischemic cardiomyopathy, that's basically everything else. And the more common causes for non-ischemic or adequate blood flow, but heart failure or the heart not working because of anything else would be blood pressure in the United States, heavy or excessive alcohol use, sometimes viruses. Chemotherapies could be a very common one. Hypertension, like I said, being the most common in the United States is very important. We call this the silent killer. So in this animation here, you see a heart that was pumping well, but over time, just because it was dealing with heavy blood pressure, that heart is starting to fatigue itself. It's getting worn out, and then eventually it gets to be this bogged down, kind of like an overinflated balloon where it's just lost its elasticity, and eventually you'll get a heart that just won't recover from its pumping strength. So again, I told you I'd show you some illustrations. Again, here's that normal pumping strength, very vigorous heart squeeze. You can see that muscle moving very excellently. But then with heart failure, unfortunately, that heart just doesn't want to move. And usually as a result, people are starting to get fatigued. They don't have the oomph. They don't have the get up and go. And so we got to make sure that we find a way to try to correct it. So what would we do to treat heart failure? Well, let's figure out what's going on. And like I told you, if this is ischemic or a problem with the blood flow, let's fix the blood flow. And we'll talk about how we do that in the plumbing issue in here in a second. If it's non-ischemic, sometimes we can't recover from that. If it's from something that's insulting the heart, like a chemotherapy, we try to remove the chemotherapy. We work with your other doctors and see if we can get this pumping strength to improve. Viruses or pregnancies can be rare causes, but when they happen, sometimes you got to give the heart every chance to recover, and with the right medications and the right therapy, we kind of hope that we'll get some recoverability, if not all, if we're really lucky. And again, the cornerstone with non-ischemic cardiomyopathy is making sure that we're on the right medications. So what would those medications be? Well, there are three medications that work hands down better than anything else. The first is something called beta blockers. And there's specific beta blockers, but I tell people these are medications that just kind of help the heart to calm down and relax and give it every chance to recover. And a lot of these are kind of hallmarked by the ending, the OLOL. So if you hear about medications like metoprolol or carvedilol or bisoprolol, those are the common ones we use for heart failure, even though they may have other causes or might be other reasons why patients might be taking them. The second type of medication class that we would use is something called an ACE inhibitor or an ARB. Even though these are great blood pressure medicines, they have some nice features that help the heart to recover a little bit more of its elasticity and try to get that pumping strength improving. And then the third class of medications would be what we call diuretics. So yes, these are medications that help get the water off, but sometimes that decongests that congestive heart failure to get people to be more symptomatically improved. So we talked about heart failure. We talked about how the heart may not structurally hold up. But what else might be part of that structural component of the house? Well, we talked about valvular disease. Inside the heart, there are 4 main valves. And I'm going to outline them here on the illustration. The first is called the pulmonary artery, the tricuspid, the mitral, and then lastly, the aorta. There are 4 valves inside the heart. There are 2 on both the red side and 2 on the blue side. The red side job is to pump fresh red blood out of the heart to the brain, to the toes, to the eyes to see, to the brain to think, to the stomach to digest food, to your muscles to do everything you like to do activities. And the blue side takes the old blood from the body and then pushes it onto the lungs so they get a chance to be renewed with oxygen and become red again. So again, what we're going to do here is I'm going to show you a little bit picture. We're going to go back to that workhorse image called the echocardiogram. And here you can see that we've added color. Nothing different than a weatherman's going to do with Doppler imaging. What we do is we turn on the color. We can actually see the blood moving back and forth through the heart. It's beautiful to see it in motion. And again, you see it move past those valves, those 4 valves inside the heart. This particular illustration, there's actually 2, the red sides that we're looking at right now. And when we talk about problems with the valves, we're typically talking about either a leak, which we call regurgitation, or stenosis, which implies a narrowing. So again, how do we treat this? Well, we treat the cause. Sometimes you can support the heart, even though the valves don't want to work great, like a door that's a little bit stuck, we can help it ease. We can get a little bit of the oil, so to speak, by giving it good medications to help the heart calm down, not work against high blood pressure. And then eventually, once the valves start to become either severe or more progressed with symptoms, we start talking about whether or not we need to repair them. Now, that typically has been historically through a surgical correction or an open heart procedure. We're now moving in cardiology and evolving into getting more procedural based, where we might be able to fix these valves from a minimally invasive approach. So again, here's a great normal looking valve. Let's show you the valves that don't look good. All right, the first illustration down on the left, same black and white image, that echocardiogram, but that valve that you see moving right in the center is very flexible. It's overly leaky. And in the center, when we add the color, you can see there's a mosaic of the blood moving back and forth. And that's because that valve is no longer closing adequately. It's flopping back and forth, and as a result, too much blood is leaking backwards. And with this particular image down on the bottom right-hand corner, this is actually a 3D image, and you can actually see the heart in motion. If you look really closely, right down this center, there's almost like a small tongue that's popping in and out, and that's a broken portion of that valve that's allowing that leak to occur. So again, with the leaky valves, becomes something that maybe we can manage medically until we get to the point where we need to repair them. But just like a door that might be stuck open, we can also have a door that's stuck closed. And in this case, we have stenotic disease or narrowed heart valve. A normal valve should open and close with a lot of ease. But a stenotic valve is something that doesn't want to open very easily. And so with this illustration we have here on the right, where the echocardiogram is showing that valve, it doesn't want to move very adequately. This is one of the most common problems that we would see in middle or later adulthood, where the valve doesn't want to open well enough that it starts to fatigue the heart or it starts to fatigue the person to them having symptoms. So this is actually one of those valves I told you we've really evolved as a nation and as a field in cardiology to being able to repair one of the more common valvular problems without surgery. And this is an illustration of a procedure called a TAVR, where we're actually inserting a new blood valve inside the heart without having to open the patient's chest. Great recovery. Most patients typically go home even the next day after this procedure. Here's a picture of it in motion. And again, you see a lot of wires, but right in the middle, that dye or that black stuff is the blood that's actually leaving the heart. And in a second, you're going to see an expansion of that same valve, that spring, so to speak, or that cage. And once it's opened up, you have unimpeded blood leaving the heart, going up to the body and brain again. So the last thing we talk about with that house is the electricity. So with the electricity, we're actually looking at how the heart is generating the motion through an electrical current. And with cardiac functioning or the electrical issues, we're typically talking about problems that may include something called an arrhythmia. Now, arrhythmia, as you may have heard as a term, is just it's a generic term to suggest that there's a problem with the normal heartbeat. A normal heartbeat should be represented with an EKG, or the electrical tracing like you see on the screen. And it occurs with the top chambers of the heart creating an electrical current and creating the first squeeze, which we call the LIV, or you hear when you listen to the heart on the stethoscope. And as that electrical current starts to pass through down to the bottom chambers of the heart, you hear the dub. So LIV dub, LIV dub. And with that lub-dub, it can be altered to the point where it's happening in a different rhythm, and perhaps that's leading to symptoms. Sometimes it can be too fast, and sometimes it can be too slow. So when we talk about heart conditions or electrical arrhythmias that are too slow, unfortunately, there's not a way to really speed up the heart with medications, but there is a way to make sure that the heart won't go too slow. And this is where people typically hear about pacemakers. So most of the time, pacemakers will not fix an abnormal rhythm, but what it can do is it can offset the problems that are created by a slow heart rhythm. Now, why would a heart be slow to begin with? Well, there's lots of different problems. It could be because of a plumbing issue or a lack of blood flow that's not allowing the heart to beat accordingly. It could be because of scar tissue or fibrosis. Sometimes it's medications. But again, if the heart's going too slow, not well enough or not fast enough to create the output that one individual needs, a pacemaker would be of benefit here. And the pacemaker would go in, typically a small device, as you can see on the screen there, a little larger than the size of a quarter, about the size of a matchbox, under the skin, into the heart, and allows to help the person regain some functionality by making sure that that heart is pumping adequately. Now, commonly, we will see heart rhythms that are going too fast, so an arrhythmia that is going too fast. Same thing, but in a different manner. When this happens, you'll see several different types of funny heart rhythms. Now, some can be normal. At the top one there is something called sinus tachycardia. Sinus tachycardia is actually a normal heartbeat that's just going faster. This one here is called atrial fibrillation. Atrial fibrillation is one that a lot of people have heard about. It's one that you often hear about medications on the news or on the commercials. Very common rhythm, which is why you hear about all these different types of therapies for it. But atrial fibrillation, in a nutshell, is where the top part of the heart is no longer creating the lub. And as a result, it starts to shiver and shake. And when you start to see it shiver and shake, it starts to create this irregular beating pattern, more of a shuddering pump, shudder, shudder, pump, shudder, pump, pump. So even though it sounds really silly to hear me say it, that's exactly what happens with the heart. Now, what do we do to manage this? Well, with irregular heartbeat called atrial fibrillation, we have three different things we worry about. The first is symptoms. But believe it or not, half the people don't even feel atrial fibrillation. And those that do feel it, even though they may feel some of the common symptoms such as racing heart or pitter-patters or dizziness, sometimes the symptoms are a little bit more subtle. Sometimes they just feel run down. They don't have the energy that they want to. Well, symptoms aside, the two reasons I really need to know about it is when that heart starts to shiver and shake. The blood is no longer pumping effectively. And you see this chaotic motion just like you see on the animation on your screen, where when the blood starts to shiver and shake and move around very chaotically, there's a potential for a blood clot to form. And this is one of the more serious things that can happen with atrial fibrillation, because if a blood clot was to form, it has the potential to leave the heart, go up the heart through the blood vessels, and that can cause a stroke. So the main reason I really want to know about is the risk of stroke. Now, the third thing that can happen is with atrial fibrillation, it will oftentimes turn on and go too fast rather than normal speeds. And if it continues too fast for too long at an irregular rate, we worry about something called heart failure. So the same thing we just talked about, the heart would start to fatigue. So again, how do we treat it? Again, we want to treat the cause. We want to know what's driving it. And if we can fix that, perhaps we can fix the problem. But even outside of that, sometimes we may never find what the driving factor is. Sometimes it's a lot of different factors that add up to one big issue like atrial fibrillation. And this is where medications can be very impactful for not only correcting the heart rhythm, but at least getting it under control and making sure we're not at risk for those problems like the stroke. Sometimes we can talk about a procedure. One of the more common procedures here is something called an ablation. So again, whether it's atrial fibrillation or some of the other versions of fast heart rhythms, if we can find that short circuit through a procedure and zap it or correct it, that might recover a patient from the problems with the arrhythmia. And then sometimes, despite our best efforts, we're really stuck with the rhythm persisting. So again, as long as we're on protective gear and making sure that we're having different types of therapies, perhaps something called an ICD, which is a form of a pacemaker, to make sure that if the rhythm starts to go out of control, there is a protective measure in there to make sure worse things don't happen. This is usually how I tell my patients we're going to tackle atrial fibrillation. At the base, you're going to have something called rate control. Now, these are the most common medications that we would use. With atrial fibrillation, we put you on the same medications that might be good for blood pressure, might be good for the heart failure, but medications that typically calm the heart down. Perhaps if we're lucky, they'll fix or correct the AFib, but a lot of times they're really there to deter the atrial fibrillation from coming back. And if that doesn't work, sometimes we move up on a step. And that second step in the tier is something called rhythm control. Now, these are where we pick medications that aren't the more common ones that would fall into a blood pressure class, or medications that could be very well tolerated. It has to be a picking and a choosing with a cardiologist to make sure the medication is right for you and right for your heart. And again, sometimes we don't have enough success with just a medical therapy, so we would go up to something called the ablation. So, and again, an ablation is something that's really evolved in the last few years. Here we're seeing different pictures of where we've outlined the heart. We know where that short circuit lives, and if we can go up with catheters and into the heart and find that short circuit and zap it, perhaps we can actually cure you of the problem. All right, so we talked about the structure of the heart. We talked about the different types of electrical issues. Now let's talk about the plumbings that we talked about very briefly previously. So the heart actually has a fuel supply of itself. And these are what we call the coronary arteries. Now, this is where we actually get the blood flow that leaves the heart. The freshest red blood, as soon as it leaves the heart, spills out into the smaller blood vessels called the coronary arteries and actually uses it to fuel the heart itself. And if we have impairments in the blood flow to the heart, this is what we call coronary artery disease. This is where classically you've heard about the elephant on the chest. Well, not everyone has elephants on the chest. Sometimes the symptoms can be very, very subtle. I've heard everything from people saying that I thought I had heartburn for the first time, or that I thought they had the flu. Sometimes I've heard of people saying, I didn't really feel much of anything until I really got very, very winded. Regardless of whatever the symptom is, the other things that can happen would be problems with the heart and not getting its blood supply and starting to weaken, or again, like we talked about, crossing over and causing an electrical issue. So what kind of symptoms do we need to look for? Everyone knows about the elephant on the chest like we talked about, but more commonly, it's men that will have the problems with actual chest pain. We know that women are going to be less likely to have chest pain and more likely to have things like shoulder pain or jaw pain. Sometimes it's on back pain. Sometimes it's something a little bit more subtle, like again, feeling suddenly tired or cold sweats. The key is that if you feel that there's something that's just different in your body, you know your body better than anyone else, you need to let your provider know or speak up for yourself, be an advocate and say, I'm really worried about something here. So this is why we're also very proud to partner with the Go Red for Women. This is an American Heart Association sponsored event. Every year we talk about women's health, and we know that women are specifically more impacted with cardiovascular disease than men. 1 in 16 women aged 20 years or older will have some form of coronary heart disease, and it is the leading killer of African American and white men in the United States, taking 1 in 5 women, with 1 in 3 being impacted with cardiovascular disease overall. So again, if you feel symptoms you just aren't sure about, and you're not certain if this represents heart, speak up, come in and make sure you get it attended to. So before we actually have the event, a lot of time we have the liberty or luxury of actually trying to figure out, is there a plumbing problem going on? And this is where commonly you've heard about people getting stress testing. Well, stress testing is a very simple concept when you think about it. It's taking 2 sets of pictures of the heart, pictures of the heart at rest, pictures when the heart works harder, and then all we do is we overlap them to look for differences. Now that picture can come in several different types of forms. The first one that you see here at the top is the plain old EKG. You have an EKG on the left that looks normal at rest, and then the EKG when the heart is working harder, where it shows a problem or a change. In the middle section, we're actually seeing a nuclear camera. So in the nuclear camera, we're actually seeing blood flow in the heart at rest. And you can see on the right-hand side of the screen that when the heart is working harder, there's now a problem in that same area on the front part of the heart where you've lost the purples and yellows and oranges, and you're seeing a darker blue or purplish spot. And in the bottom, finally, we're using the echocardiogram, where on the left screen, you're seeing the heart pump beautifully at rest, and when the heart is working harder, there's now a problem with a certain area not pumping quite as strong. These would all imply a problem with a blood flow to the heart in a certain area. Now, how would we get to the heart from the rest to the working? Well, that's where the classic treadmill comes in. If you can get the heart to work harder and you mimic an actual physiological event, it gives us a lot more information. But we also realize that because of knee pains or surgery problems or general health concerns that maybe not everyone can get up on a treadmill, and that's where we've developed chemical versions. Now, the chemical versions don't actually stress the heart or make it work harder. And by a certain physiological principle, it actually relaxes the blood vessels, but it still allows us to give us a really good illustration of whether or not there's a blood flow problem. So what actually happens if there weren't preceding signs and we're actually having a heart attack? Well, again, this is typically because there's a blockage in the heart that's been brewing. Smaller blood vessels that are trying to feed the heart start to adapt, and they start to slowly fill with a small clot that then gets bigger and bigger and bigger until eventually you'll have a sudden blockage like you're seeing in this animation. In this particular animation, there was a small nidus for a problem, and depending on how fast it wants to all of a sudden erupt, you will start to have the heart struggling for immediate oxygen, and it will start to suffocate and literally start to die or kill the muscle off. So how would we fix this? Well, if we have enough time to prepare based on a stress test, we would go through something called a cardiac catheterization. If we don't have that, we're having a sudden heart attack, this would be something that we would prepare for much urgently. But a cardiac catheterization does two things. First, it identifies an actual problem. So it's diagnostic, but at the same time, it gives us a chance to be therapeutic. And this is where we heard about maybe people getting a heart stent. The heart stent is what would be delivered through a cardiac catheterization. This first animation shows the typical route, which is where the blood vessel goes into the IV goes into the leg, and then something called a catheter, which would be about the size of cooked spaghetti, would work its way up into the heart with a trained cardiologist, and this is where we could deliver therapy. The more common way that we're doing it currently, or in kind of the modern age, if you will, is trying to go through the wrist. So a lot of people have had a lot of discomfort by going through the blood vessel in the leg. If we could change and go through the wrist, which is a little bit more of a common practice nowadays, it does give people a little bit more comfort, and it tends to have a little bit less of a concern with recovery afterwards. Regardless, this would be something you talk about with your cardiologist if there was a problem with the stress test. Now, when we actually go up with the cardiac catheterization, this is where we can deliver the stents. A stent is a small piece of metal that is inserted beyond the blockage, and then you will have it expanded with a balloon. And with everything goes well, you will actually see that clot or that narrowing pushed off to the side. So kind of like we saw in the animation where we were fixing the heart valve goes in through the narrowed portion and then expanded to correct the area, a very similar concept. These stents then become part of your blood vessel wall. They don't move, they don't shift. Eventually your body will create a layer of skin, if you will, around that stent, almost like a tree that grows around a chain link fence, and this becomes a permanent part of your body and will correct a blockage. Now the stress test, here's a beautiful illustration of a stress test. I told you two sets of pictures. On the bottom pair of each set of images, you're going to see blood flow that fills in uniformly and beautifully in the heart. And you see the red arrow, which identifies the change in that blood flow. So this would have been a patient that came in with preceding symptoms, got a stress test because they spoke up and said something doesn't feel quite right. The stress test surely identifies this concern about a possible blockage, and then we proceeded with the cardiac catheterization. In this particular illustration, this is a patient's cardiac catheterization. The catheter goes up through the arm and finds its way right to the heart, and this is where we can see the blood vessels. This first one shows the blood vessels on the left side of the heart that look beautiful. The one right down the middle, called the anterior descending, the one off to the side that calls the circumflex. They have a few little small, mild changes, but nothing that identifies a problem that fits the stress test. Now conversely, when we look at the backside blood vessel, there is a problem right in the center. You can see when that illustration goes through, there is a problem right after that first branch that comes off, a very significant narrowing. And after the heart had a chance to get the stent, it was filled in very uniformly. So what happens after we get a stent? Well, after we get a stent, a lot of times people hear about being on blood thinners. Well, these medicines that we put on aren't actually blood thinners, but what they do help do is they reduce the potential for a scab to form inside that clot or inside that stent as it's healing. The last thing we want to do is put a fresh stent in that opened a blockage, and then the heart starts to clog back up. And with blood still moving back and forth across that stent, just like if you were to cut your skin, there's a potential for the body to create a small scab or narrowing or clot. So what we do is we put people on medications. The most common one that you might hear about is something called Plavix. There are some other options out now called Brilinta, Effient, but again, these are brand name medications for therapies that would help that stent to heal. Now, this will often be required for up to 1 year. Sometimes shorter, sometimes longer. It's up to the discretion and discussion with you and your cardiologist, but this is an important thing to know about whether you're going in with a loved one or going in with the expectation of maybe getting a heart stent, is understanding that when these stents go in, they will obligate you to medications for up to 1 year. So if you're having something like a surgery or bleeding issues, this is something that you need to make sure to be aware of beforehand. So again, now that we've kind of understood the common ailments that people will come to the cardiologist for, I want to make sure we get a chance to identify what would predispose us to having one of these issues. What can we do to make sure that we're not suffering or treating, having to go down the pathway of treating one of these issues? Well, a lot of it comes down to risk factors. Some of these risk factors we can't control. We can't control the fact that the longer we're on this earth, that we're going to have more of a potential for cardiovascular disease. Sometimes we can't control the fact that if we're a man or a woman, or where our genetic makeup comes from. But fortunately, by this illustration, you can see that a lot of the risk factors that are very important in developing cardiovascular disease are things that we can modify ourselves or with the help of a practitioner. So within these modifiable risk factors, the first one is hypertension. We're not going to go through all of them, but I want to make sure to pinpoint a couple of the highlights on some of the important ones. People know about blood pressure being 120 over 80. A lot of people think a normal blood pressure is such, but that's not actually true. A normal blood pressure is actually less than 120 over less than 80. And previously, these would be the guidelines that we would adhere to. We would say, okay, we will start medication once the blood pressure is over 140. Well, a few years ago, American Heart Association, American College of Cardiology said we need to be treating this more aggressively. Well, why did we do this? Well, we realized that blood pressure, again, is called the silent killer. And by just changing the guidelines and treating earlier, starting therapy or intervention at blood pressures of greater than 130, we know that we can save countless events. And again, those countless events are stroke, heart attack, and death. So a 38% rise in the number of high blood pressure deaths between 2005 and 2015. This is one of the reasons we're treating earlier and more aggressively. And you can see that just on the right-hand side of the screen, the risk of stroke greatly increases when that blood pressure starts to rise. So this is one of the more important reasons that people are doing fine until they're not with high blood pressure. Cardiovascular disease. At years of follow-up, you can see that patients that have remained with elevated blood pressure, so again, it's that area that might be in that gray zone or historically would have been kind of lost to just simple observation, after several years of follow-up, we're increasing our risk of an event substantially. With stage 2 hypertension, we're greatly increasing those odds of cardiovascular deaths, strokes, and heart attacks. So again, we want to treat much more aggressively. So how do we treat blood pressure? Well, we're going to talk about diet and lifestyle changes in a minute, but the more common things you're going to see with medications will be something called calcium channel blockers. Calcium channel blockers are great medications that relax blood vessels, and the common ones you'll hear about are something called amlodipine or verapamil or diltiazem. The side effects typically are very minimal. Sometimes you can have side effects like mild slowing of the heart rate or a little bit of swelling, sometimes a little bit of fatigue. But again, any of these concerns, if you're on those medications, having those symptoms, talk it over with your provider. Maybe there could be an alternate or substitute. Maybe something else is going on. Outside of calcium channel blockers, another common form of medications might be called the ACE inhibitors or ARBs. Now, you heard about these before. You heard about these when we were talking about ways to help that heart recover or improve its pumping strength. Again, great blood pressure medications, commonly ending with the terminal endings on the names of PRIL or SARTAN, so lisinopril or losartan. The way these work is they actually work through the kidneys to help relax or reduce the release of certain chemicals that would then squeeze down on blood vessels and increase blood pressure. One of the more common side effects with the lisinopril or the ACE inhibitors is cough. About 15% of the people will have this persistent nagging cough, and it can really occur at any time. So again, side effect you might want to look out for or talk with your provider if you're experiencing. One of the more rare ones that can happen is actually a swelling of the mouth and face, and this can actually occlude the airways. So angioedema is one of the more serious side effects. So again, if you've ever had any of these side effects for any other reason, talk to your provider about them. So outside of those other classes, some of the other medications you might hear are, again, the diuretics, commonly broken down to different diuretics, the thiazides or hydrochlorothiazide or chlorthalidone, mild diuretics but have excellent blood pressure control. Loop diuretics tend to be a little bit more pronounced on the way that they have the body release the water from the system, and that really can provide a decongestion for people that are bogged down from breathing issues or swelling in the legs, but typically have a little less of a blood pressure effect. Then there's a class of diuretics called potassium-sparing diuretics. Now, these are great for patients with heart failure because they do have some other properties that help that heart to recover. With any diuretic, you always run the risk of having some type of dehydration, which then can impact the kidneys, or electrolyte abnormalities where the body is urinating off too much of the certain chemicals that we need for daily function. Some of the other ones you might hear in kind of passing are beta blockers. These used to be more commonplace. We talked about some of these with the heart issues like heart failure. Don't have great blood pressure effects, but could be very helpful in the right circumstances. Clonidine, methyl-dopa, some of the older versions, again, have a certain place. Hydralazine is another common one you might see on patients' list when they're taking, but again, have different properties, but typically have different pros and cons with them. So when we talk about another modifiable risk factor, a lot of people know that cholesterol can be an issue. So regardless of your approach on cholesterol, there's no way of getting around it that the higher the cholesterol numbers, the higher the potential for having a cardiovascular event. And when we talk about cholesterol, we're usually looking at not only specifically the type of cholesterol or levels of cholesterol, but what is the breakdown of the cholesterol. So I always tell people that more commonly we're looking for the LDL. The LDL is the lousy cholesterol. That's the stuff that really has the potential for creating that plaque buildup in the blood vessels of the heart, setting us up for risks of blood flow problems or heart attack or stroke. The HDL typically is actually the good cholesterol, so H being healthy, if you will. So the healthy cholesterol can actually be a nice offsetter for the bad cholesterol. All right, so again, when we talk about the different types of cholesterol, LDL being the one that we really want to focus on, the lousy cholesterol, if you will. So some people that really have a little concern about whether or not there's true causality here. And regardless of your personal viewpoints, there's no denying the fact that, like I said, the higher the LDL or the higher the cholesterol levels, the higher the potential for a cardiovascular event. And in this illustration here, you can see that once we hit an LDL level of 190 and higher, there becomes a substantially higher risk for cardiovascular death. Even at cholesterols that are more modest, 120 to 150, 160, there can still be an increased risk. So again, if there's concerns about whether you need to be on medications or whether there is something other than diet and exercise that we can do to drop your cholesterol, talk with your provider or your cardiologist. So how would we bring the cholesterol down? Well, again, we're going to talk about diet and exercise, and good dietary and lifestyle changes should never be underestimated. But when it comes to taking medications, the ones that have shown hands down to have the best bang for the buck are the statins. So again, statins, despite all the publicity that they receive, have this tremendous impact in not only lowering cholesterol numbers, but doing something else to reduce your risk of cardiovascular stroke, heart attack, and death. And we think it does this by several different types of factors, and we call this a pleiotropic effect. And one of the things that we think the statins do more than any other medication is it probably stabilizes the plaque or the blockage that might be unstable and potentially at risk for having a stroke, heart attack issue. Medications outside of the statins, there's another one called ezetimibe, which goes by the brand name Zetia. Now, it was really good at helping to block some cholesterol absorption, and fish oils, and Vascepa and Repatha. All these other medications, even though there's a lot of promise with them, we have not seen them have the same potential benefits as the statins. But again, if there's a concern about whether or not a medication is right for you or not, you talk with your provider. So when we start talking about the different things that we can do to offset our potential risk, I want to talk about what we can do from other methods. What can we do from the diet and exercise? Because this, again, hands down, should be the cornerstone for anyone's health. You put the good gas in the car, you're going to get the best out of it. So what do we do for any medical problem? We treat the cause. If there's a problem with obesity, we try to work on diet. If there's a problem with sleep apnea, we start working on therapy. If there's a problem with another medical issue, let's treat that as well. But with diet and exercise, this can be the difference between no medications or multiple medications. And I will often tell my patients several times that if we can get off smoking or tobacco, or if we can start to do things to better our lifestyle, that could be the difference between being on multiple meds or even no meds at all. So when a patient comes into my office, I often will tease them. I say, what do you think a cardiologist is going to ask you if I tell you to go out and get an exercise program going? And I think a lot of people will be a little daunted that they may be expecting to hear something like you need to go out and train for a marathon or you need to train for some high level of exertion. And that's not necessarily true. The American Heart Association has shown that if you can do 30 minutes, 5 days a week of simple activity like walking, or 150 minutes total a week, your risk of stroke, heart attack goes down by 1/3. Your risk of cardiovascular death goes down by 1/2. And not only does this simple number right here improve your cardiovascular health, but it can also reduce your risk of diabetes, dementia, even certain cancers like breast cancer. And the powerful effect on the blood pressure is also should not also be underestimated. It could actually drop your blood pressure for about 5 to 10 points with simple weight loss. So again, there's a cumulative effect here. The more weight loss we do, the more exercise, the less likely we are going to have to be on medications or chase the stuff that will lead us to another issue. So we start talking about just the role of diet and exercise. There's one study that showed that even though the response might be a little bit variable, if you can drop about 10 pounds of weight loss, you can actually lose about 3 to 5 points on your blood pressure. So again, 20 pounds of weight loss, which is not uncommon for a lot of American individuals to have excess weight, that can mean up to 10 pounds of blood, or 10 points on your blood pressure. So again, the difference between a medication or not. So again, I can't emphasize this enough. Diet can be the single most powerful influencer. The American diet is typically high in salt, dense in calories, and has a tremendous amount of processed foods. And if we can start to replace this little by little to incorporate foods that are rich in nutrients, especially potassium that replaces the sodium, unprocessed whole foods, and be smart about the types of foods we're eating, you'll make a tremendous impact on not only your health, but your overall bottom line with your wallet, your waistline, and you're going to feel so much better too. So very briefly, the 2 diets that I typically will advocate in my practice would be the DASH diet, which stands for Dietary Approach to Stop Hypertension, and the Mediterranean diet. Again, there's subtle differences, but the key being is that you're actually incorporating holistic foods. You're trying to reduce those processed foods. The DASH diet tends to be the one that you limit the sodium very substantially, and you can actually have the powerful blood pressure drops. The Mediterranean tends to have a lot more robust evidence about reducing your stroke, heart attack through the inclusion of the richer fatty acids, the really healthy stuff that really gets the diet going. So again, common things: lower sodium, it reduces the constriction of the blood vessels, it reduces your ability to retain water, more potassium and magnesium, it relaxes the blood vessels, less processed food, you're getting lesser calories, lesser sugar, reduces the cortisol, the inflammation. All these things would put you in a better position for long-term health and especially your cardiovascular health. So in summary, I want to make sure you guys know your body. Like we talked about with symptoms, if something just doesn't feel right, you stand up, you come in, you let us know so we can figure out what's going on. And whether that's a structural problem, an electrical problem, or that plumbing problem, we'll help you out. Know your numbers and know your risks. Know the profile that you have and how your certain risk factors might increase your potential for having a problem, or how you can fix those to reduce maybe a second problem. And then remember the role of diet and exercise as well as prevention for keeping good long-term health. And I thank you all very much. I'm very pleased to be again here with the LIV program. Thanks.